Next speaker is Dr. Raju Sampangi. He is a senior veterinary surgeon practicing at Netra Spandana, Nagar Bhavi, Bangalore. He'll be talking about the role of rTPA, recombinant TPA. Is it a first line or reserved as a second line? Where does it work best? Dr. Raju, please.
Thank you, sir. Thank you, Dr. Dipender, for including me in this IC. And let me see whether I can convince you to use a TPA from your rheumatic retinopathy. So, this is the brief overview of what I'll be speaking, basically a rationale for the use, the history in the background, and what works, whether it's intravitreal or subretinal, whether we should use it with gas or without gas, and the timing, and some practical aspects about the preparation of the drug itself. As far as indications for TPA is concerned, acute thick submacular hemorrhage in the subfoveal region, recent onset, would be an indication for use. And why you require treatment early is we know that there is clot contraction, there is toxic effect of iron and a diffusion barrier that leads to photoreceptor damage, and it happens as early as 1 day. So going back to our MBBS days, this is how the clotting mechanism would work. The thrombin would work on fibrinogen to convert into fibrin, and this would be a part of the clot. So what we are interested is in this part, the tissue plasminogen activator. So whenever there is an injury, the platelets are recruited and they get activated, and then they start collecting. And the thrombin acts there and it binds these platelets into a with a meshwork leading to a fibrin mesh. So this is how the clot looks like, and the TPA would act on the plasminogen, which is bound to the fibrin, and convert it into the plasmin, and after that these strands which are holding them are broken down. So this is how it works like. As far as role of TPA in subretinal blood is concerned, there are many animal studies which establish the role for subretinal TPA. So how does it, which works? Is the intravitreal better or subretinal better? Actually, the reports are very confusing and very contradicting. This report showed that intravitreal TPA doesn't diffuse through the intact neural retina and reach the subretinal clot at all. While this study published in Retina revealed that intravitreal TPA actually is present in the subretinal space after you inject, and it results in rapid clot lysis in rabbit eyes. And another study shows that intravitreal taken place in pigs was able to penetrate when given intravitreally. This is another study published recently around 2017 in rat model, wherein they use alteplase in unconjugated TPA, and again it was injected into the vitreous and it was capable of penetrating deep into the retinal layers. As far as the clinical studies are concerned for intravitreal TPA, Heriot was the first one to report its use in a clinical meeting, while Payman used subretinal TPA in a surgery in 1991 itself. So it's almost 2.5 decades. If you look at the various studies which are there, there are many studies wherein the intravitreal TPA has been used. Here they compared the subretinal and intravitreal TPA, and they conclude that both treatment modalities effectively displace the submacular hemorrhage in this exploratory trial. This is another study published in Eye, wherein they said that the intravitreal TPA was valuable for submacular hemorrhage only in eyes with relatively old hemorrhages, and for eyes with recent onset hemorrhage, TPA is suggested only if the initial gas injection failed to displace. That's what they concluded. This is another study wherein they compared subretinal versus intravitreal. Again, according to their conclusion, both treatments proved equally efficacious. This is one more study published in Retina, wherein they had 39 eyes and they did into 3 groups. One was a vitrectomy with subretinal TPA. Second was intravitreal TPA with pneumatic displacement. And third was only pneumatic displacement. What they found was in both the intravitreal and the subretinal TPA group, that's the TPA group, they had good improvement in vision, while the patients with only pneumatic did not improve. But the number of patients were less, I would say, around only 9 patients in the pneumatic displacement group. But they said that the pneumatic only displacement did not work well according to this report. But does only TPA, intravitreal TPA work? It doesn't work. So if at all you have to do it, you have to do it with along with a pneumatic retinopexy. Now again, that begs back to the question that what is working? So I would still say, I would go with Dr. Dipender and say that if at all I have to give an intravitreal TPA, I would combine it with a pneumatic displacement. So this is one case that has been published wherein it shows that intravitreal TPA plus gas does work. And this is when you give subretinal, definitely it is a yes, but it comes with its own set of risks. Now if you compare these two images published in the same publication, you can make out that the intravitreal TPA has almost worked as good as the subretinal TPA if you look at compare the images and the way it has responded to the treatment. So intravitreal TPA has its advantages in being simpler with lesser risk of complications and being more accessible because you don't have to perform a surgery. While it may have limited direct exposure to the clot itself. While subretinal TPA is the place where you should give the injection, that is where the clot is, so it will be more rapid and effective in clot dissolution comparing to the intravitreal TPA. However, it's an invasive procedure, requires a surgical expertise and higher risk of intraoperative complications. Now, in which patients to consider subretinal TPA? The thickness of the hemorrhage is one thing that I think is very important. In thick hemorrhages, especially if it is more than 250 to 300 is what many studies take, and some of them say it is 450 microns. But if you feel it's a very thick hemorrhage and the vision is less, then one should consider subretinal TPA in these patients. And when it acts best, as soon as possible is the answer for that. Of course, there are other factors, patient factors that we need to consider before we take these patients for surgery. As far as complications of use of TPA is concerned, the patients can end up with a vitreous hemorrhage, a rebleed, high IOP, retinal detachment and macular hole whenever we are injecting in the subretinal space. Again, the toxicity can also be dose dependent, and any dose which is more than 50 micrograms is said to be toxic. So a dosage of 25 microgram is recommended for use. Now coming back to some of the drug practical aspects, which drug, dosage and preparation. So as far as the streptokinase is concerned, it binds to both bound and unbound plasminogen. So and high antigenicity, it is not usually used. And while the alteplase, retiplase, or technetoplase acts on the bound plasminogen. However, alteplase is the most commonly used one. And compared to both of them, the other one, TNK, is supposed to be more efficacious in clot thrombus dissolution, at least. Now, how to prepare? This one, the Actylase comes in 10 mg. So it comes in 2 bottles, a dry and a bottle with a saline, and you have a connected to it. So you open both the bottles and connect the saline into the dry powder, and the fluid goes into it, and then you just shake it. At 10 mg is there in 10 ml now. That gives us 1 mg in 1 ml, and take 1 ml of this and make it up to 10 ml using sodium chloride, and gives us a concentration of 100 microgram in 1 ml. And we can inject up to 0.25 ml of this drug, of this 100 gram in 1 ml solution. These are the various cannulas that are used to inject, and some of the specialized injection kits are also available for this. Now, as far as TPA being used in submacular hemorrhage, you also have the choice of using an anti-VEGF. Now, there is one report which says that when you combine it with aflibercept, it actually cleaves that, and because of that, the effect of aflibercept is less. So, this is one thing that we have to keep in mind when we are combining it with TPA. So, the management of submacular hemorrhage presents a complex and challenging scenario. There are various things that we need to consider, but one thing we can probably consider is adding it intravitreal, which is the most easiest thing to do. So, in real world, what happens is basically when the patient is there, the ideal situation is to give it subretinal TPA doing a surgery, while practically what many of us can do is to give the intravitreal gas as a first aid, as Dr. Dipender sir said. If you see this patient had a blood pressure of 200 by 140 3 days before, and he came with a submacular hemorrhage, probably a ruptured ram. We gave him a pneumatic displacement. You can see very beautifully this blood got displaced, and the vision improved from hand movements to 6 by 36 at 1 week. Now, one more important thing is in patients with RAM, they have a risk for rebleed. And all eyes in this study, in this published study, all eyes who had a macronism had a rebleed. So the clot was actually plugging it, and you lyse it, so it may lead to a rebleed. So this thing also we need to keep in mind, and in these patients maybe a pneumatic displacement would be a better choice. To answer all our questions, RCT is under progress, the Tiger study, and hopefully it will answer many of our questions. So ultimately, it's imperative to weigh the potential benefits against the risks and limitations of each approach while considering patients' individual circumstances and preferences. Thank you so much.
Thank you, Dr. Raju, for doing excellent work and very nice presentation. You have done justice to the topic. And